Greetings of the day, folks. Today we are going to discuss about altered mental status in children. So, altered mental status is characterized by failure to respond to verbal or physical stimulation in a manner appropriate to children's developmental level. So, the ED incidence of altered mental status is widely depending upon the institution reporting, varies, and the population served and specific definition of the altered mental status. So the children with altered mental status require simultaneous stabilization, diagnosis, and treatment. Okay. So the objective of treatment are to sustain life and prevent irreversible CNS damage. Once patient is resuscitated, goal is to determine the cause and stop the disease progression. The arousal by now coming to the pathophysiology, the arousal is mediated by the neural pathways of ascending reticular activating system that project from brainstem to hypothalamus. Okay, so it will and thalamus and cerebral cortices. So the ascending reticular activating system regulates wakefulness in response to environment as well as homeostasis, cardiovascular, and respiratory functions. Altered mental status occurs through dysfunction of ascending reticular activating system, an insult to bilateral cerebral cortices, or global depression of central nervous system. There are many factors that can cause dysfunction in the ascending reticular activating system and cerebral hemispheres, including inadequate substrate for metabolic demand and or sufficient flow, presence of toxins or metabolic waste products, or alteration of body temperature. Okay, typical causes of bilateral cortical impairments are toxic and metabolic states that deprive the brain of normal substrates. Okay, so there are multiple pathologic conditions that affect awareness and arousal. Etiologies can initially be described as traumatic or non-traumatic. Non-traumatic causes can be further divided into structural and functional. Structural lesions can be categorized as supratentorial or subtentorial. Signs and symptoms of supratentorial lesions include focal motor abnormalities, which are often present from the onset of ultimate level of state consciousness. Subtentorial lesions lead to reticular activating dysfunction, okay, in which prompt loss of consciousness is common. So the cranial abnormalities of frequent and abnormal respiratory patterns are seen. So the functional etiologies include infectious, inflammatory, nutritional, toxic, neurologic, or psychiatric disorders. Okay. Depressed consciousness is typically seen before motor signs become depressed, and when present, motor deficits are typically symmetric. Okay, so now we have discussed that. Okay, so in supratentorial, focal motor neurological deficits are more commonly seen. Okay, it is present from the onset of cortex. In subtentorial, it lead to reticular, in which prompt loss of consciousness is common. Okay, so that's what we have to be remembering. Okay, so depressed consciousness is typically seen before motor signs become depressed, and when present, motor deficits are typically symmetric. Okay, so this is pathophysiology. Now coming to the clinical features, the clinical features it will range from confusion, delirium to lethargy, stupor, or coma. A lethargic child has decreased awareness of self and the environment, obviously. So the patient may be aroused from an apparent deep sleep, but they immediately relapse into a state of minimal responsiveness. A stuporous child has a decreased eye contact, decreased motor activity, and intelligible vocalization. Stuporous patients can be aroused with vigorous noxious stimulation. Comatose patients are unresponsive and cannot be aroused by verbal or physical stimulation, such as phlebotomy, arterial catheterization, or lumbar puncture. Okay, so rapidly assess and support the airway, ventilation, and circulation. When the patient is stabilized, take a methodical approach, and comprehensive history. And so comprehensive history include what? Table 40, 141. So important historical elements for evaluating altered mental status in children. So the prodromal, like we have to ask for any prodromal events such as recent illness or infectious exposure because it might be the trigger, and history of any recent trauma. So if there is any bleed to inside the brain, so this may be causing it. So risk factors and include medications in the home, social environment, vaccinations, family history, developmental milestones. So we have to ask about all these things because any of these might be a risk for the patient, for the baby. Okay, so the associated symptoms might be make us like pin down to a certain diagnosis. Okay, so associated symptoms include constitutional fever, weight loss, GI, vomiting, diarrhea, abdominal pain, neurological headache, gait, seizure activity, weakness, palpitations, and musculoskeletal head tilt or rash. Okay, dermatological. Okay, so after knowing about this, we have to ask about like, so this is an expansion of the table. So after like before, we have to ask about the prodromal events before change in consciousness, as well as recent illness or infectious exposure determine likelihood of trauma, abuse, or ingestion. Inquire about antecedent fever, headache, head tilt, abdominal pain, vomiting, or diarrhea, gait disturbance, seizures, drug ingestion, palpitations, weakness, hematuria, weight loss, and rash. So, for infants and children, review developmental milestones. The medical immunization and family histories are important in children of all ages. Okay, so medical immunization and family histories are important in children of all ages. We have to be alert for any inappropriate responses, inconsistencies, or delays in seeking care that may arouse suspicion for child abuse. We have to proceed with a general examination only after respiratory, cardiac, and cerebral stabilization. The objectives of the examination are to include occult or to identify occult infection, trauma, toxicity, or metabolic disease. The neurological examination should document the child's response to sensory input, motor activity, pupillary activity, oculovestibular reflex, respiratory pattern. Although several coma scales have been published such as a modified Glasgow pediatric Glasgow coma scale, the most simplified and functional scale in emergency is AVPU. So A is awake, B for verbal response to verbal stimuli, P for response to pain, U for unresponsive. The Glasgow Coma Scale lacks good interobserver reliability and reproducibility and does not accurately predict outcomes in individual patients. The AVPU scale has been validated and currently recommended by Pediatric Advanced Life Support Guidelines. Okay, that is pulse. The AVPU corresponds to Glasgow Coma Scale of 15, 13, 8, and 3. Okay. After obtaining a comprehensive history and performing complete physical examination, including thorough neurological exam, anticipate and carefully observe for improvement or deterioration. Okay, so we have to carefully observe for improvement or deterioration. Once the child is stabilized, the history and physical examination suggest either a medical disorder or a structural lesion. The mnemonic is AEIOU. So the mnemonic is AEIOU tips. So A for alcohol, E for encephalopathy, I for insulin, O for opiates, U for uremia, T for trauma, okay, I for infection, P for poisoning and seizures. It is a useful tool for organizing the diagnostic of altered mental status. So let us see the table. Okay, A for alcohol, right? A for alcohol. Alcohol, in this we find ethanol, isopropyl alcohol, methanol, concurrent hypoglycemia is common. So acid-base hypotonic and hypertonic hepatic dysfunction, inborn errors of metabolism. And A for also arrhythmias, cardiogenic, mainly stroke, atoms, supraventricular tachycardia, aortic stenosis, heart blocks, tachycardial tamponade. E for encephalopathy, like causes a race syndrome, parainfectious encephalopathy, autoimmune encephalopathy, such as anti-NMDA receptor encephalopathy, posterior reversible encephalopathy syndrome may be associated with hypertension, autoimmune disorder, autoimmune disease, Shanley purpura, and endocrinopathy. Addison's disease can present with a altered status of psychosis. Thyrotoxicosis can present with ventricular dysrhythmias. The pheochromocytoma can present with hypertensive encephalopathy. Electrolytes, hypo or hypernatremia, and disorders of calcium, magnesium, and phosphorus can produce altered mental status. So alternative status and I for insulin, right? So alternative status from hyperglycemia is seen in severe diabetic ketoacidosis as well as hyperglycemic HHS, that is. And hypoglycemia can be a result of many disorders, and irritability, confusion, seizures, and coma can occur with the blood glucose levels less than 40. Okay, intussusception. Hyper also intussusception may be initial presenting symptom. Then coming to O is opiates. Common household exposures are lomotil, diphenoxylate, natropine sulfate, Imodium, loperamide, diphenoxylate, and dextromethorphan. Clonidine and alpha agonists can also produce similar symptoms. Okay, so oxygen, O for also oxygen. Disorders of airway, breathing, circulation may adversely affect the oxygen delivered to the brain, and hypercapnia from the primary lung disease or neurological. U for uremia. Hemolytic uremic syndrome can produce altered status in addition to abdominal pain. Thrombocytopenia, purpura, and hemolytic anemia also can cause altered status in children with chronic liver failure. Neurological dysfunction may develop secondary to stroke, hypertension, or metabolic derangements. T for trauma. Trauma is hypovolemia or hemorrhage from multi-system trauma may lead to insufficient cerebral perfusion and result in altered mental status. Consider concussion, hemorrhage, contusion, epidermal or epidural or subdural hematoma. Consider non-accidental trauma. T for tumor also. So tumor is primary metastatic or meningeal leukemic infiltration. Intracerebral tumors commonly produce focal neurological signs. Posterior fossa tumors typically block the ventricular system and create signs of hydrocephalus. Shunt malfunction should be considered among patients with VP shunt for hydrocephalus. Thermal hypo or hypothermia, progressive hypothermia may lead to serious altered stress. I for infections, bacterial meningitis, encephalitis, brain abscess, usually present with fevers. Brain abscess is characterized by fever, headache before altered status. Presenting symptoms also include generalized or focal seizures. Okay, so any systemic infection associated with vasculitis or shock may lead to altered status secondary to cerebral hypoperfusion. Okay, so and also I also includes intracerebral vascular disorders such as subarachnoid, intracerebral, intraventricular hemorrhages can be seen with trauma, rupture aneurysms, or AV malformations. Venous thrombosis can follow severe dehydration, okay, or pyogenic infection of mastoid orbit, middle ear, or sinuses. Arterial thrombosis is uncommon in children except in those with homocystinuria. Okay, and also intracerebral and interventricular hemorrhages may follow birth asphyxia or trauma in neonates, but in older children that they may be signify congenital or acquired coagulopathy. Cerebral emboli from bacterial endocarditis may cause altered mental status. Yeah, acute confusional migraine may be associated with profound alteration in consciousness. Okay, so children with sickle cell anemia can develop cerebral thrombosis, status epilepticus, and coma. And psychogenic, P for psychogenic, right? So it is decreased response with normal neurological examination, including oculovestibular. Psychogenic unresponsive may be conversion reaction, adjustment, or panic state or malignant. And P also includes poisons such as drugs, toxins, illicit substances that can be ingested by accident or through neglect or abuse or in a suicidal gesture. Okay, S for seizures. Generalized motor seizures and absence seizures are often associated with prolonged unresponsiveness in children. In child with history of seizures who presents with AMS, consider non-convulsive status epilepticus. Febrile seizures are seen in children aged 6 months to 6 years. So, if a metabolic cause is suspected, obtain serum electrolytes and renal hepatic function studies, serum ammonia, CBC coagulation studies. Okay, if the history and examination suggests toxic ingestion, obtain serum levels of suspected agents in the urine tox screen. Consider trial of an antidote if available. Obtain ABG, CBC, pulse oximetry in cases of trauma, respiratory distress, or suspected acid-base imbalance. Obtain 12-lead ECG and provide continuous cardiac monitoring if there are pathologic auscultative findings, rhythm disturbance, or suspected toxin exposure. For serious bacterial infection, obtain blood and urine cultures. Okay. Correct shock, hypotension, and hypoxia before attempting lumbar puncture. Okay. Then clinical scenario directs imaging. So immobilize cervical spine and radiograph. The cervical spine is spine injuries present, suspected, or in case of multiple system trauma, if an intracranial lesion is suspected, or if there are focal neurological signs, obtain an NCCT of head. If vascular injury is possible, they consider CT angiography of head and or neck. A chest radiograph confirms and or clarifies the findings and documents the endotracheal tube placement. Abdominal radiographs are indicated to assess for acute ingestion of radiopaque material. Okay, abdominal ultrasound may be useful to screen for cases of interception. Other studies may be useful in specific causes. Specific cases are serum osmolality, blood alcohol level, thyroid function tests, blood lead level, and skeletal survey for suspected abuse. EEG will evaluate for non-convulsive status epilepticus. So the treatment principles we are going to discuss separately on a table form. Okay, so begin with airway, breathing, circulation, and administer 100% oxygen until adequate oxygenation is confirmed. For suspected increased intracranial pressure, elevate the head of the bed to 30 degrees, establish an IV and normal saline to restore and maintain perfusion, obtain a stat point of care, glucose, and treat hypoglycemia. If the history or exam suggests opiate toxicity, give naloxone. For suspected meningitis, give antibiotics and acyclovir. Okay, so let's see the treatment part in more detail here. Okay, so general treatment of altered we have to assess airway, breathing, and circulation. We have to immobilize the spine for suspected trauma and initiate continuous pulse oxy, consider capnometry, and also administer oxygen if the patient is hypoxic. Give dextrose for hypoglycemia. For children, give 25% dextrose in water, 2 ml per kg. For newborns, give 5 ml per kg of 10% dextrose in water. Okay, 5 ml per kg, this is 2 ml per kg and 10%. Provide fluid resuscitation 20 ml per kg of isotonic crystal oil and repeat a total of 60 ml per kg as needed. Administer broad spectrum antibiotics for suspected sepsis or meningitis. Give naloxone for suspected opiates or clonidine overdose. 0.01 to 0.1 mg per kg IV every 2 minutes. Okay, so 0.01 to 0.1 mg per kg. And administer flumazenil for suspected pure benzodiazepine overdose, that is 0.01 mg per kg. Control seizures with benzodiazepines like lorazepam 0.0 mg per kg and diazepam 0.1 mg per kg, midazolam same 0.1 mg per kg, and also prevent or treat hypothermia with heat lamps during resuscitation. Treat hypothermia also. Now, coming to the disposition part, once the patient is stabilized, the child should be observed until his or her mental status improves. The patient condition, clinical condition, and specific disorder dictate whether the further management can occur on inpatient or in an ICU. Okay, so only patients with transient reversible causes may be treated, monitored in the ED, and discharged after observation and return to the baseline mental status. Patients who are discharged, those with close head injuries or simple febrile seizure, should receive disease-specific discharge infection instruction. Children who are evaluated for altered mental status and discharged home should have repeat evaluation within 24 hours of discharge. This completes the altered mental status in pediatric patients. Thank you very much for your patience.